Hello, everyone. Welcome and thank you for joining us for this educational session. And we're launching off a month of Smilow Shares talks. This is the first of four. This is entitled Empowered Through Knowledge. And we have four, well, in addition to me, three great speakers today. I think you're going to enjoy this overview. I'm going to be the first speaker. And if you don't know me, I'm a breast surgeon at Greenwich, but hailed from training at Yale. I went to Temple Medical School and then matched at Yale and have been in Connecticut ever since. After training at Yale, and there were 2 years at the National Cancer Institute, I came back to Yale, finished my training, and stayed on as an attending for 10 years before coming down to Greenwich. And life comes full circle. I'm back as a Yale faculty, and I'm thrilled to be there and with all of you today. And next slide, please. And as you know, it's October, and it's the month where we celebrate survivors. Next slide, please. There are now 4 million breast cancer survivors in the United States. And, we know that this is a common disease, but fortunately, most patients survive. And looking at some of the current statistics, next slide, that the American Cancer Society estimated that there would be 313,000 new breast cancer diagnoses this year, with unfortunately still 42,000 deaths. And it is the most common cancer among women and the most common cancer. Thankfully, not the most lethal. Next slide. And interesting facts that you can see from this slide, if the print's a little bit tiny at the bottom, but there was sort of a peak for some reason in 2000 with cancer diagnoses, went down, which looked hopeful, but now it's been slowly on the rise over the last 2 decades. So this is a disease that's destined to be with us. And again, very common. Next slide. And this slide represents the incidence of cancer in the United States. You can see that the darker blue is not good. That's a higher incidence, meaning per capita. And I often say that the Northeast, what's a risk factor for breast cancer? It's like living in the Northeast. And does it have anything to do with our pressured lifestyle? It's hard to know. Possibly part of this, though, is early detection. We maybe have a more compliant patient population. The Northeast may have a slightly higher concentration of Jewish patients, and breast cancer is more common among Ashkenazi Jewish patients. But we're definitely in the hotbed of where breast cancer occurs. And all the more reason to have these talks and keep us all well informed, get everybody out for early detection, which is the best chance of cure. I didn't mention yet much about men. And interestingly, this is really amazing, but I'm caring for a 98-year-old male right now. I'm sorry, 97-year-old male with breast cancer right now. And I'm only stating that because it's true that we're all at risk, right? Male and female. And I don't want to forget about talking about men. Men need to report if they have a new mass in their breast, if something feels funny. It's a very uncommon disease in men, but it does occur. And so we are all at risk and need to be alert. So next slide, please. So I'm going to provide a bit of an overview as to the history of how breast cancer treatment has evolved. And in the past, there was really just one treatment. It was radical mastectomy. Interestingly, my mom was a long-term survivor of that. She had breast cancer diagnosed at the age of 38. She had the classic Halsted radical mastectomy and lived to be 89. Having said that, though, you'll see how things have changed so dramatically in my personal lifetime. And so now it's more about individualized treatment, tailored treatment, and less radical surgery per se. And I think the theme of a lot of what you might be hearing today is that we're trying to de-escalate, meaning one size doesn't fit all, and that there are patients that don't need as aggressive treatment as we've done in the past. And that's really part of the theme of where things are right now. Next slide. I've already mentioned this, so next slide. William Halsted is the father of modern surgery. He developed aseptic technique, anesthesia. He also began sort of the way residencies occurred and training that was more formalized at Hopkins. He did attend Yale as an undergrad. He was the captain of the football team. One funny fact is that they said that he had never taken a book out of the Sterling Library. So that's on record, which is kind of interesting. Next slide. So what started to change, this movement? So a little bit of it was mammography, that the mammogram became invented. It was a way to lead to early detection. And next slide. As well as the possible use of combining surgery with breast radiation. Dr. Campbell will talk a lot more about that. Next slide. And chemotherapy came into development in the 30s to the 60s. Next slide. And interesting, some of the earliest pharmacists that developed chemotherapy were at Yale, and Goodman and Gilman are given credit to that. So we have inherited a legacy of research and innovation. Next slide. So in the 1980s is really when lumpectomy became more popularized. I personally remember that I was doing a rotation at the University of Pittsburgh where Dr. Bernie Fisher had helped with some of these early trials, proving that lumpectomy and radiation had the same survival as a mastectomy. And I remember carrying that paper. It came out in 1985 that he published, hoping to run into him and possibly get a signature on it. I did get to meet him, but I didn't ask for the signature. Anyway, next slide, please. Let's move ahead. The 80s also were when many of the mammography trials were occurring, and they were demonstrating that if women had mammograms, it led to earlier detection and improved survival rates. And so that was really significant, because, we kind of take it for granted now, but in the past that we had to prove with good reason that it made a difference to get a mammogram, and that early detection made an ultimate difference in survival. And that's still the theme for today. We talk about mammograms don't pick up everything. And yes, we definitely know that we have to add in our ultrasound when women are dense. And that's kind of old news also in a way. We're proud that in Connecticut, we were the first state to know that we had to add in ultrasounds. But screening clearly improves survival, no question. Next slide. So what else was happening? And the BRCA genes have not that long ago, right? We recognized the importance of the BRCA1 and 2 genes, and also that patients that carried those genes would have a higher incidence of second breast cancers as well. But it was another population to look at more closely, that they would be more likely to develop breast cancer than somebody who didn't carry a gene. Next slide. And again, the sentinel lymph node biopsy technique was developed actually in Vermont by Dr. Craig, who first employed this technique. We were a part of that. Was just like in the very, very beginnings. And I can remember how it happened for us incorporating it at Yale in the first place in Connecticut in 1997, because it's the year my daughter was born. And I was actually breastfeeding her when I had to give the talks about us utilizing sentinel node and teaching the techniques to the other surgeons. So it's kind of sealed in my memory that's 1997 was when it was brought to Connecticut, and has really made a major impact in trying to minimize the aggressive surgery that we used to do. I used to think, when I was first taught, that if I retrieved 20 lymph nodes, I had done a really good job. Unfortunately, if those 20 lymph nodes could be completely negative, and the person would go on to arm swelling and lymphedema. And so, like, now we really changed the way we think about, like, we don't try to clean out the axilla, so to speak. We try to take the least nodes possible. And then many times now we're backing off on particularly women who have good prognosis tumors. We know that's highly likely the node will be negative. And especially somebody my age, we wouldn't do a sentinel node biopsy even, because the likelihood of the positivity would be so low. But that's, again, in patients that are being screened. The screening population, you pick up things early, small, usually less aggressive, and you can back off of the more aggressive treatment. Next slide. So trastuzumab and anastrozole, big words, right? So those were really important findings in the late 90s, and we'll talk a little bit more about that. Next slide. And so basically, now when I have a conversation with patients about, they've had their mammogram, they have a finding, they have a needle biopsy, it shows a positive for cancer, how important it is to know the results of the tumor receptors. And I can share sort of an anecdotal story where, in this way, I can share this because Joan London has written it in a book, and so it's public information. But she was somebody that was cared for in our system. And in her book, she says, well, I found out on Monday that I had cancer, but I couldn't be seen by Dr. Ward till Thursday. And I'm like thinking back, like, really? Like, I don't think so. I think we didn't really have a path report, right? And so we actually didn't have a path report until she's in the office. Path report comes in, and all of a sudden I'm used to, saying, oh, the receptors, they're probably positive, and, ready to get through my spiel. Well, I bring in the path report, and she has a triple negative breast cancer. I'm sitting across the table from her, seeing this for the first time. And she said, in retrospect, that she could just see that my countenance changed, that we were in for a more serious conversation. And she was off to neoadjuvant chemotherapy. Thankfully, she's recently announced that she's a 10-year survivor of triple negative breast cancer. She also touts the fact that her cancer was found on ultrasound, not on mammo, and the importance of knowing your breast density, et cetera. Next slide. So I'm going to go through these relatively quickly, just to, again, score the fact that we need to know the receptors, because it completely changes how we think about if the patient's going to have surgery first, or they're going to be referred to a medical oncologist to consider neoadjuvant treatment. Next slide. So basically, the luminal A, luminal B, that means these are tumors that have positive estrogen and or progesterone receptors, as opposed to tumors that are positive for the HER2/neu marker. That's a sign of more aggressive cancers, and most, if not all, not quite all, but patients with a HER2 positive breast cancer, which is, again, as a receptor, will go on to Herceptin treatment plus others. And then next down the line, the worst prognosis typically has been triple negative. There's been amazing advances, which you're going to hear about, but those tend to be more aggressive. Next slide. So how do we look at the receptors, right? So this is a slide that kind of shows that it's a color thing, that once there's a cancer diagnosis, the pathologist does staining, and they will identify on the right, you can see the color that shows up bright as a positive estrogen receptor and a positive progesterone receptor, as opposed to the left, which is more bland. Next slide. Similarly, there's an analysis for the HER2 new marker. And so on the upper slide is, again, that staining process that we talked about, but that's a visual and it is a subjective analysis by the pathologist. But it's kind of clear that slides all the way to the right, that stains positive. The one on the left, that's a 0, that's negative. But in between the 1s and 2s, particularly the 2s, they have to be subjected to a backup test to confirm the positive and negative. And there's another test called FISH testing. And so once again, it's visual, but it's a little bit more technical and it gives a little bit more detail. And this is a really fascinating area, though, because the patients that maybe test a little bit positive, but not a 3+ positive, maybe have some benefit to Herceptin and other drugs like that. And so that's an area of active research. Next slide. So without talking much about it, so neoadjuvant means we give chemotherapy or other treatments to shrink tumors prior to surgery. And then the surgery is performed on a smaller tumor. Sometimes we know that if the tumor completely disappears, that means that treatment was effective. So it's almost like you have your own petri dish, analyzing what you've just done. Like, in other words, like, you know, how if you have an antibiotic, did it work or doesn't it work? Same kind of thing with this, where if the tumor completely goes away, you know that treatment worked. If it didn't completely go away, you know you have to add additional treatment for that patient. Next slide. This is an example of somebody that did have a fairly large tumor, triple negative, prior to surgery. Next slide. And then you can see how much it shrunk. And she was able to have a more effective lumpectomy following that treatment. Next slide. And just briefly, talking about the sentinel node as opposed to removing 20 nodes. A dye is injected in the breast. There's a couple different ways to do it, either a radioisotope, meaning a very, very low level of radioactivity, and there's like a beeping sound, like beep, 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 shows me where the lymph node is in the armpit. So the dye is injected in the breast. It travels through the lymph system and it gets stuck in something called the sentinel node. So we know that cancer cells will take the same track as the dye, and they'll get stuck in the sentinel node. So that's how we know which node to remove when we're in the operating room. You can also use a blue dye, and then there's a blue lymph node. Next slide. So again, the goal is to remove only the nodes that are essential without removing all of the nodes. Next slide. And that's sort of, again, a way that the surgeries become less and less. Like, less is more, you know, is sort of the theme. Just remove the node that you need, but not necessarily all of the nodes. And if you think about it, if there's a positive lymph node and you're a surgeon, of course you want to take those positive lymph nodes out. But you also want to do that with a minimal impact to long-term recovery, long-term range of motion, minimize lymphedema. Next slide. And negative node means no cancer in the sentinel node. Positive lymph nodes means that we did find cancer. Next slide. And briefly, I'm just going to talk about lumpectomy versus mastectomy. And overall, we feel that we prefer to do lumpectomies when we can for small cancers. There's no survival benefit to doing a mastectomy as over lumpectomy. And then some patients think, well, if I do a mastectomy, I'm not going to need my chemotherapy. And that's not true, right? The indications for chemotherapy are based upon what's the risk to your body not the risk to your breast. So once again, we prefer to do lumpectomy, most oftentimes followed by whole breast radiation, as opposed to mastectomy, because the survival, there's no survival benefit. One might say that there's got to be somebody out there that was destined to have a second cancer. And because of that, they live longer because they had the mastectomy. And I do think that's true, but rational thinking would say that's true for the youngest patients, right? If you're diagnosed with breast cancer at 35, you have a whole life ahead of you where you might have a second cancer. And so those are patients that if they feel that they want to perform a double mastectomy, even, we're more agreeable. I do have occasionally an 80-year-old that comes in, I just want both my breasts off. It's like, I can't say it's malpractice, but close to malpractice to do a double mastectomy in an elderly patient because of the risk of surgery with absolutely no survival benefit. And this is the picture to the right just shows the traditional way of doing a lumpectomy, or where a wire is placed that shows us where the spot is because we can't feel it. And then once removed, we take a picture that documents that we've removed that. This picture actually comes up in the operating room. And this wasn't one of my cases because the cancer would be right in the middle of that specimen, I think. I'm just joking. But it just lets you know that if you see a picture like this in the operating room, we see that real time, and we know that we should take that an extra margin, particularly a big margin to the left of where that came out. Next slide. And in addition to the wire, just brief mention of there's many other ways to localize a cancer. One that we employ is something called a Savvy Scout, which is this tiny little radar detector. So it's an interesting alternative to the wire localization, and another innovation, but there's multiple other ways to do the localization. I still feel for most cases that the wire allows me to know exactly in a three-dimensional sort of sculptor way of where my target is and where I'm headed. But many surgeons have their pet way that they feel is the best way for them to accurately get a cancer out. Next slide. And then just super briefly, we talk clearly about the options for mastectomy, for skin-sparing mastectomy versus nipple-sparing mastectomy. Our next speaker is going to talk a lot more about these different options. And mastectomy is clearly always an option, and it's a very personal choice for patients if they actually have the option of one choice versus another. But I look forward to hearing Dr. Haykal's talk as well. I think next slide, I'm pretty sure that's it. So without further ado, I'm going to introduce our next speaker. And Dr. Siba Haykal is the section chief of reconstructive oncology for the Division of Plastic and Reconstructive Surgery, and she's an associate professor of surgery within our Department of Surgery. She is double-boarded, certified plastic and reconstructive surgeon. She's an acclaimed specialist in microsurgical reconstruction, which is one of the relatively new things in the history of breast reconstruction. She has years of experience in delivered care for breast cancer patients. She specializes in autologous-based reconstruction. That means using one's own tissue. She offers innovative techniques for restoration of breast sensation and immediate lymphatic reconstruction following lymph node dissection to prevent lymphedema. She has extensive experience in treating lymphedema and offers lymphovenous bypass and lymph node transplantation. She joins the Yale School of Medicine Department of Surgery after being recruited from the University of Toronto and the University Health Network for several years. She was named as an honoree for Canada's top 40 under 40. I think that's really cool, in 2021. And she's the recipient of the American Society for Reconstructive Microsurgery Women in Microsurgery Travel Scholarship and a Hugh G. Thompson Humanitarian Award for her clinical, academic, and research. So, Dr. Haykal, thanks for joining us.
Thank you so much. Thank you, Dr. Ward. Thank you for your presentation. And thank you to all the participants for being here as well. I'm going to share my talk. And let me know if you can see it okay.
Yep, we're good.
Great. Thank you so much. So I'll be talking about reconstruction after breast cancer and what your options are. So the timing for breast reconstruction is either immediate, which means at the time of the mastectomy, or delayed, which means any time after mastectomy. There are two types of breast reconstruction, either tissue expander implant-based reconstruction or autologous-based reconstruction, which is using your own tissue to create a breast mound. How do we determine what the best option is? So it really depends on your preference, the need for any such as chemotherapy or radiation, available donor sites, and we'll talk about that, other medical issues, as well as recovery time. So these are the different types of reconstruction that we can do. The first one is aesthetic flat closure. So what does this mean? So following mastectomy, a plastic surgeon can be involved to really excise or remove extra skin and make sure that there isn't any redundant skin after mastectomy. And this allows for nicely shaped scars and to make sure that there's a nice aesthetic closure. Another way that we can do breast reconstruction is what we call oncoplastic reconstruction after a lumpectomy. So what this means is that we're rearranging the breast tissue after a lumpectomy to really achieve the best aesthetic result. So when a portion of the breast is removed, it can cause some dimples, some divots in the breast, and it can cause some asymmetry between the two breasts. So it's a good option for patients who have large breasts or very tautic or what we call saggy breasts. And typically we also do a breast reduction on the other side to get them to match, knowing that a lumpectomy goes hand in hand with radiation and that we have to account for some changes that will actually come from radiation as well. Another type of breast reconstruction is implant-based reconstruction. So for this, we can either do a one-stage direct-to-implant reconstruction. So that means that we put an implant at the time of mastectomy. It eliminates the need for tissue expansion, which we can talk about. It can be completed in one step. And candidates are really based on breast size, the tumor size, how far is the tumor from the nipple, and the type of mastectomy that's required. However, a one-stage direct-to-implant is not the gold standard for implant-based reconstruction. The gold standard is a two-stage procedure. So this is what a tissue expander looks like. So a tissue expander looks like a deflated balloon that has a port, and this port is a magnet. It's placed either under or over the muscle, and then you come to the clinic every week, 1 to 2 weeks, and we use a magnet finder to find this port and fill up this balloon with some saline. So this allows to expand the skin, and our goal is to create new skin so that we can make room for an implant. So this is a two-stage procedure, which means that at the first stage, we put the tissue expander, we fill it to the desired size, and then we go back to the operating room where we remove the tissue expander and put an implant in. So this is an example of where the tissue expander would sit. So typically, and most commonly now, it sits above the muscle, the pec muscle. And we also sometimes use different types of meshes. So either an alloderm sling, so that's a cadaveric mesh, where the cells have been removed and it's been processed. This allows to support the expander or the implant. This is before a mastectomy. This is what tissue expanders would look like. So they sit high, they're filled with fluid, they feel a little bit more fake. And this is after an exchange for permanent implants. The implants are softer. The implants are filled with silicone. They're like gummy bear silicone, where if you cut into it, it doesn't leak everywhere. What are the possible complications with implant-based reconstruction? Most of the time, there are no complications. They tell us the shelf life of an implant is about 10 to 15 years. The body sees the implant as a foreign body, so it will develop what we call a capsule around it. That's a normal reaction. Sometimes that capsule can get hard, can get tight, can distort the implant, can cause it to become painful. And that is more likely to happen if radiation is also used. You can always have some contour irregularity or some wrinkling, infection, a fluid collection, or a blood collection. These are examples of a patient who had an immediate reconstruction with implant-based. So again, the nipple and the areola were removed in this case. This is a nipple-sparing mastectomy. This is before the mastectomy, and this is after the mastectomy here on the right, where the incision is located in the fold. We preserved the nipple and the areola, and the implant was placed immediately. This is an example of a patient who had an implant and then had radiation. So radiation can cause some damage to the skin, which can cause some changes in the skin, like skin color, and can cause the implant to get harder. The advantages of an implant-based reconstruction is that it's a quicker procedure, it's a shorter recovery time. You get to choose the size of your reconstruction and only operating on one site. The disadvantage is it could be more than one surgery. We can sometimes see and palpate the implant. If it's placed under the muscle, you can have some chest wall animation. There's a risk of infection, capsular contracture, rupture. Radiation can lead to high failure rate. And then there's two things that we hear a lot about in the media, something called anaplastic large cell lymphoma, which is a fluid collection that forms around particular types of implants. These are textured implants and not commonly used anymore in reconstruction. The other thing is called breast implant illness. And sometimes there is some patients that we know that do not do well with implants, whether they have it for reconstruction or augmentation purposes. We think there might be an underlying autoimmune disease that could be associated with that. So another way that we can do breast reconstruction is using your own tissue. So there are different places that we can take it from, the most common one being the belly or the abdomen, but there are other different spots as well, and you might hear about it as labeled as flaps. So there are different types of flaps. So these are all the areas that we can potentially take it from. And we're using your own tissue to create a breast mound. We're avoiding all the complications with implants. It's a pretty nice donor site. So back in the day when these were first described, we utilized the skin and the fat along with the muscle that is located in the belly. That was called a tram flap. So now we have more advanced techniques where we use microsurgery, and I'll basically talk a little bit more about what that means, where we disconnect the tissue and reconnect it. So this is a cross-section of the belly and of the muscle that is in the belly. These little vessels are less than 1 millimeter in size. So we typically use imaging to try to visualize and identify those vessels ahead of time. And during the surgery, we find those vessels, we follow them all the way down to the groin, we disconnect them from the groin, and we reconnect them in small little vessels that are about 2 to 3 millimeters in size that are located underneath a small piece of the rib. So we're operating close to the lung. And then you end up with a scar from hip to hip and a scar around the belly button. Similar scar to a tummy tuck scar. So we also, and very recently, I started using a nerve graft to try to bring back sensation into these flaps to allow for restoration of sensation. So one side, in order to do this for one side, it takes about 6 to 8 hours. Both sides take about 10 to 12 hours. We would be in the hospital for about 2 to 3 days. The first 24 hours are the most important because that's when we watch to make sure that the connection that we've made between those vessels is working well. And then we monitor very closely with different monitoring devices. These are some of the monitoring devices that we're looking at, using Doppler signals as well as some infrared imaging. Most of the times there are no complications. We try not to take any muscle, but we have to operate within the muscle in the belly, and that could potentially cause a hernia or a bulge in a small portion of cases. There could be some delayed wound healing, some infection, some fluid collection or blood collection with any types of surgery, and there's a small chance that we cannot make this flap work. The chance of that happening is very, very low. These are examples of a patient, this was before a mastectomy, where the nipple and the areola was removed, as well as all the breast tissue. So the skin was left behind. So we filled that skin with some tissue from the belly, including skin and fat. And the scar is from hip to hip, and a scar around the belly button, like typical, like a tummy tuck scar. And we gave the patient a little bit of a lift at the same time to provide a nice aesthetic result. This is another example, so we can do it in people of different shapes and sizes. A delayed reconstruction, that was an example of an immediate reconstruction, meaning that the mastectomy and the reconstruction were done at the same time. This is an example of a delayed reconstruction, so meaning that the patient had a mastectomy and a scar and came back to have this type of procedure done. So we borrowed skin from the belly, and you can see that we were able to create a breast mound, and the scars look a little bit different because we have to borrow a bit more skin from the belly because all that skin from the mastectomy has now been removed and also has now been removed or scarred down on the chest wall. Delayed immediate reconstruction is another type of technique that we can use. So that's when we use a combination of your own tissue as well as a tissue expander or an implant. I'll show some examples of that. So what are the possible complications related to breast reconstruction with using your own tissue? The advantages are most of the reconstruction is done at the time of surgery. We're using your own tissue. It's lifelong. It's the best substitute for natural looking breast, and the benefit is a tummy tuck. The disadvantage, it's a longer procedure. It's a longer recovery time. So you're in the hospital for about 2 days, but it's 6 to 8 weeks of no heavy lifting, pushing, or pulling, mainly because of the belly. It's a separate donor site. Just like any surgery, you could require revisions. There's always a small possibility of losing the flap. I can only use the belly once, and there's more scars. So implant plus autologous, an example is using the latissimus dorsi or the back flap. So this is skin, fat, and muscle. It's sometimes used after lumpectomy defects, for example, where I use the skin and the fat from the back in combination with an expander or an implant to bring back that shape after a lumpectomy. Or it can be used to recreate the breast tissue completely. So this is an example of a delayed reconstruction using the back flap as well as an implant. The advantage is we can use it in patients who previously had radiation, who still want implant-based reconstruction. There could be patients who the belly is not an option or are too thin to have it. The disadvantage is all the same risks as implants and all the risk of using your own tissue from another part of the body. Now, the last thing that we do in the cases where the nipple and the areola is removed is we reconstruct the nipple and areola. And this is completely elective. It's done no earlier than 3 months after the initial reconstruction. It could be done under local anesthetic if there's still sensation in the breast. It's a short recovery time. And then we tattoo the areola, which is done after the nipple reconstruction. So it's a little bit like origami, where we flip some tissue and we make a nipple out of it. This is not like a normal nipple. It doesn't have sensation. It doesn't change with temperature, but this is what it would look like. And then we have our APP do the tattooing. These are examples before tattooing and after tattooing. This is a patient who had breast reconstruction using her own tissue from the belly. We can tattoo them different colors. And this is an example of a 3D tattoo where we do not take any tissue or bunch it up, but instead we use very different tattooing to try to make it look like there's an elevation. So this is a 3D tattoo. So thank you so much for listening, and I'd be happy to welcome any questions at the end of this talk, and please feel free to email me or message me. Thank you so much. So I would like to introduce our next speaker. So Dr. Mariya Rozenblit is an assistant professor of medicine in the section of medical and cares for patients with clinical focus on breast cancer. She completed her fellowship in medical oncology hematology at Yale, her residency in internal medicine at NYU, and received her medical degree from Icahn School of Medicine. She's involved in educating medical students, residents, and fellows at Yale. Outside of the clinic, her focus is on translational research with an interest in biomarker-driven trial development in breast cancer. In 2020, she was a recipient of the ASCO Young Investigator Award, which is incredible. And in 2022, she was a recipient of the Susan G. Komen Career Catalyst Research Grant.
Thank you so much for that warm introduction. Thank you so much for having me here. There is a lot to cover in medical oncology. So what I wanted to focus on was kind of a couple of questions about how to de-escalate, how to escalate, and how to really try to tailor therapy for our patients with some of the more aggressive breast cancers that Dr. Ward had mentioned. So one of the big questions currently in the field is, can we start to think about de-escalating chemotherapy, especially in young women with hormone-positive breast cancer? So a long time ago, we used to give a lot of chemotherapy for hormone-positive breast cancer, and then there was a test developed called the Oncotype, which took a piece of the tumor itself and sent it off to a special lab and comes back with a score telling us what is the risk of this cancer coming back not only locally in the breast, but in other parts of the body and potentially coming back as metastatic breast cancer. And what we learned is that the score, if it's over 25, shows a benefit to chemotherapy and reducing the risk of breast cancer coming back as a metastatic type of breast cancer. We then had data that there was a big trial called R-Exponder that showed that a lot of this benefit from chemotherapy seemed to depend on menopausal status. So postmenopausal women, even if they had up to 3 positive lymph nodes, and we know that the more positive lymph nodes there are in the axilla, the higher the risk of the cancer potentially recurring. Even if they had positive lymph nodes up to 3, and a low Oncotype score, we could avoid chemotherapy in these patients because in hormone-positive breast cancer, it really is driven by hormones, estrogen and progesterone, and we can get a lot of benefit out of giving what we call endocrine therapy. It looked like young women who are premenopausal had a benefit if they have positive lymph nodes, regardless of the Oncotype score. And there was a big question of, is that benefit really from the chemotherapy itself, killing the cancer cells, or is it because chemotherapy puts young women into early menopause? And we know that chemotherapy does that. Most women stop having periods while they're receiving chemotherapy. We know that women have a lower ovarian reserve after chemotherapy and can have a harder time getting pregnant after chemotherapy. So the R-Exponder trial, even though it showed this benefit in young women, unfortunately did not answer the question of why we're seeing this benefit, because very few patients on the trial received ovarian suppression. So in our young women who are high risk for breast cancer coming back, the standard of care now is to give them ovarian suppression. And what that is an injection that actually prevents the ovaries from releasing estrogen and puts women into early menopause. So on both arms of this big trial in which we interpret the oncotype data, on both arms, very few women received ovarian suppression. We also saw that of the women who did stop having periods during the first 24 months of follow-up on this trial, that did seem to be associated with improved outcomes, but it was a very small sample in which they collected this data. So it's unclear, like we mentioned, what exactly is this benefit from chemotherapy? So most recently, this summer at ASCO, they went back and looked through this data, and they were able to look at something called AMH levels. So anti-Mullerian hormone is a marker of ovarian function and postmenopausal status. It's often used by gynecologists. And so a high level means that there's a good ovarian reserve and that these patients are premenopausal. And so when they went back at this data and looked at these levels, they saw that in the 79% of premenopausal by age, so young women, that had chemotherapy benefit, they had these high AMH levels. So they had good ovarian reserve and were actually premenopausal. The 21% of young women who did not seem to benefit from chemotherapy had low AMH levels. And so most likely, despite being young, they were already entering early menopause that we just were not aware of. So does this directly answer the question? No, but it's starting to suggest that perhaps the ovarian suppression and the early menopause that chemotherapy induces may have a larger role to play in this than just the chemotherapy alone. So how can we answer this question? There is a big national trial currently going on, specifically in this population of young women who are premenopausal, who have this intermediate recurrence score of 21 to 25, or a lower score with other high-risk features, or if they have a positive lymph node. So particularly, we're interested in young women who are premenopausal who maybe have one positive lymph node, whereas usually just one positive lymph node makes us concerned enough to give these women chemotherapy. And it's randomizing to either standard chemotherapy plus everything that we would normally do, which is ovarian suppression, giving endocrine therapy for at least 5 years, versus no chemotherapy and just suppressing the ovaries. So I think this is an ideal trial to answer this question, although I think very hard to think about participating in as a patient, because it is a very personal decision whether you want to do chemotherapy or not. But this is just to give an idea that this is enough of a debate in the oncology community currently, and we think it's safe enough to do this big phase 3 trial to look at randomizing thousands of women, because we think ultimately, hopefully, ovarian suppression will be just as good, and we can start to avoid chemotherapy in women who might not need it. Okay. So the next question is, how can we try to escalate and improve our treatment in our high-risk patients with hormone-positive breast cancer? So immunotherapy is finally entering the breast cancer field. It has been kind of ahead in lung cancer and some other cancer types, and we are seeing benefits. So right now, it's currently standard of care with triple-negative breast cancer. With hormone-positive breast cancer, there is some interesting data coming out that it might benefit a subset of patients. So there were 2 trials. One is the Keynote 756, which looked at high-risk patients, so large tumors, positive lymph nodes, and grade 3. So when we look at under the microscope, it looked like they were very aggressive tumors, and randomized patients to either standard chemotherapy that we would normally give versus chemotherapy plus immunotherapy. This was given before surgery. And then at the time of surgery, they wanted to see, did they have this complete response that Dr. Ward mentioned? Did the tumor completely die off at the time of surgery? There was a very similar trial called Checkmate that looked at also this question using a slightly different immunotherapy drug, but very similar chemotherapy. And what they showed was that there was an improvement in this complete response when patients got to surgery. And even though these are small numbers, this is a pretty significant improvement because in hormone-positive breast cancer in general, the reason why we often don't give chemotherapy before surgery is because we see really small numbers of this complete response. And part of that is we think because endocrine therapy is probably more effective in this cancer type. But in this particularly aggressive tumor type, we did see an improvement suggesting that immunotherapy might have a role to play. And when we say immunotherapy, these are drugs that activate your own immune system, your own immune cells to recognize and attack the cancer cell. So there's some promising data. It's still early. We're still awaiting long-term data to see how these patients do over many years. But it may become approved in the future for perhaps a specific subset of what we think are the most aggressive hormone-positive breast cancers, and most likely will depend on some kind of analysis where we're looking at either the tumor itself or other biomarkers to help us predict who will benefit, because there are toxicities to immunotherapy that are not trivial. So currently, there is a trial going on that Yale is participating in through SWOG called S2206. And what this is looking at is using something called MammaPrint, which is very similar to Oncotype. And tumors that have an ultra high score, so they have the highest risk of recurrence, randomizing those patients to either standard chemotherapy or standard chemotherapy plus immunotherapy. And this is based on some other trial data that showed that, once again, these most aggressive, highest risk tumors seem to benefit and seem to have that higher complete response with the addition of immunotherapy when they get to surgery. So how can we also tailor treatment to reduce risk of recurrence after surgery in hormone-positive breast cancer? And I'm sorry that this talk focuses a lot on hormone-positive. It's because we have just more recent drugs in hormone-positive breast cancer. So most recently, the NATALEE study ended up in approval, FDA approval for ribociclib in the adjuvant setting. And it showed that after surgery, when patients had some high-risk features, whether it was a larger tumor or a high grade under the microscope or positive lymph nodes, after surgery, in addition to endocrine therapy, receiving a CDK4/6 inhibitor, so a pill that prevents the cell from dividing, in addition to an estrogen receptor blocker, seemed to reduce further the risk of this cancer coming back. And so when they compared the combination to an endocrine blocker alone, there were lower numbers of the cancer coming back. And so right now, we actually have two of these drugs approved, abemaciclib and ribociclib. They're very similar. We think they're probably equally effective, but ribociclib, the FDA approval includes lymph node negative tumors as well. So even if there might not be a positive lymph node, if it's a tumor on the larger side, if there's a high oncotype, if there's other clinical features that might make your oncologist worry about this cancer coming back, that's another option to add to your treatment to reduce the risk of this potentially coming back as metastatic breast cancer in the future. And there will be trials in the future comparing these two drugs to try to figure out, are they equal? Is one better than the other? What about triple-negative breast cancer? So as Dr. Ward mentioned, triple-negative breast cancer is our most aggressive type of breast cancer with the worst predicted survival and the highest risk of recurrence. And for a very long time, we always gave standard chemotherapy, which includes anthracyclines, which are a type of chemotherapy that do have a small risk of cardiac toxicity and do have a small risk of leukemia. And so how can we tailor chemotherapy or think about tailoring chemotherapy in this very aggressive breast cancer type, but think about maybe minimizing toxicity for our patients in the future? So for large tumors or lymph node positive tumors, immunotherapy has now become standard of care in addition to chemotherapy before surgery. And we think that the addition of immunotherapy is actually so helpful for triple-negative breast cancer that we're starting to study whether we can avoid using the anthracyclines. So using other chemotherapies like Taxol or paclitaxel, carboplatin, other types of chemotherapy drugs that don't have this risk to the heart and don't have this potential risk of leukemia. And so there are two trials out now that have looked at this question. So triple negative breast cancers, where patients were randomized to either standard chemotherapy or chemotherapy drugs without the anthracyclines plus immunotherapy. And what they saw was that the complete response rate when these patients got to surgery was actually pretty similar between the two groups. So 53% is about as good as we get with standard chemotherapy. And there are some biomarkers that seem to predict a better response rate. So if somebody has something called PD-L1 positivity in the tumor, that predicts as high as a 71% rate of getting that complete response. And if there are already lymphocytes, which are a type of immune cell that are infiltrating the tumor, that also seems to predict a higher response. And so we do now have some data to suggest that the immunotherapy might increase the effectiveness of the chemotherapy, that we might be able to avoid anthracyclines. And so there now is a large phase 3 trial open across the country in which Yale is participating in, looking at this question. So randomizing patients to just carboplatin, docetaxel, and immunotherapy versus the anthracyclines plus the chemotherapy plus the immunotherapy. And this is just a schema in case anyone's interested. So what about metastatic breast cancer? For hormone-positive metastatic breast cancer, first line still remains CDK4/6 inhibitors. So those are the cell cycle inhibitors that we mentioned, plus some form of endocrine therapy, so some form of estrogen receptor blocker. And so these are both pills, and we have several different CDK4/6 inhibitors, and they all seem to be pretty effective in terms of preventing the growth of the tumor on scans. We have not compared each CDK4/6 inhibitor to each of the other ones, so we assume that they're equivalent. They have very different side effects, so most of the time we pick based on side effects. There is now improving overall survival data coming out for ribociclib in particular, so patients who stay on ribociclib seem to live longer, perhaps, than the other two. There's some question about whether that's because of the drug or because of the way that the trials were designed. But at Yale, if we're starting somebody new on a medication, we tend to start them on ribociclib. If someone has been on palbociclib for years and is doing really well, we, of course, would not switch that because ultimately they're probably pretty similar. Now in the second line, we have a new medication approved called capivasertib, which is a type of inhibitor particularly targeting PI3K, AKT. And so these are some of the mutations that a tumor might acquire as it becomes resistant to treatment. And there was this big trial showing that capi plus fulvestrant, which is a common injection that we give that degrades the estrogen receptor, the combination was better than fulvestrant alone. So what we do in the second line is usually try to rebiopsy, which for a long time we had to do tissue, but now there are a lot of blood tests that are called liquid biopsy, where we can do a simple blood test and try to see if there are these mutations being developed by the cancer, and we can try to think of more targeted therapy if there is a mutation present. So Capi was just approved back last year in 2023. For PIK3CA, AKT, or PTEN alterations in the tumor. There is currently now Capitello 292. So this is actually looking at first line, particularly in patients who might have a more aggressive type of cancer. So in the first line setting, if they have been on endocrine therapy and now have a metastatic recurrence, either while they're on endocrine therapy or within 12 months of starting it. And so these tend to be more aggressive tumor types. And so they're looking at doing triple therapy, capi plus fulvestrant plus the CDK4/6 inhibitor. And this is a trial that's currently open at Yale. Just to make everyone aware, there is a new drug coming down the pipeline called inovolisib, which is another type of PIK3CA targeted drug. And so we might have more and more of these in the next couple of years as they continue to be developed and more data comes out. The exciting thing in general is new antibody drug conjugates. So these are antibodies with a little bit of chemotherapy attached to, once again, try to make the treatment more targeted. The exciting one that's out there currently is called Dato-DXd. So this is an antibody to something called TROP2, which seems to be present on a lot of breast cancer cells, not just so HER2 triple negative might be present in hormone positive breast cancer as well. And it's usually better tolerated than general chemotherapy and more targeted because the antibody binds to cancer cells and the chemotherapy goes directly into the cancer cell. So there's been exciting data in hormone positive breast cancer that it's most likely Dato-DXd is more effective than our current standard chemotherapies. And so this is showing improvement in progression-free survival. And right now, we actually have 3 of these antibody drug conjugates out there: Dato-DXd, sacituzumab, which is currently approved in later lines in hormone-positive breast cancer, and T-DXd, which is currently approved for HER2-positive metastatic breast cancer, and also something called HER2-low, where we're seeing that even tumors that have just a little bit of staining tend to respond to this antibody drug conjugate. So there's more of them coming out. We're probably going to see more of them in the next couple of years. And it's very exciting because they seem to be a little bit less toxic than general chemotherapy and probably ultimately will be shown to be more effective than chemotherapy. So for hormone-positive metastatic breast cancer, we first start with endocrine therapy and the CDK4/6 inhibitors. In the future, we might have this triple therapy with inovolisib for really aggressive tumors. And then once the cancer progresses, we try to see if there are these targetable mutations. There are just a couple listed here for which we currently have treatments available, and those also tend to be pill form, which is nice. Then after that, we do have to move on to chemotherapy, or if there's no targetable mutations. And then after chemotherapy, we do have these antibody drug conjugates that are an option, and they will probably move up in the pathway as they're shown to be more effective than general chemotherapy. And then Dato-DXd is the one that I mentioned, which might become approved soon in the next couple of years. For HER2-positive breast cancer, the exciting thing that was reported in our research meetings last year, was that specifically for breast cancer that has metastasized to the brain, so when there is cancer cells in the brain, tucatinib plus TDM1 might be a very promising therapy. So TDM1 is also one of the antibody drug conjugates that targets HER2, so there's a little bit of chemotherapy attached to it. And tucatinib is an oral type of therapy. And now that they're combining it, it seems to be effective even in patients who have what we call active brain metastases. So even before they receive a radiation treatment to the brain, this might be just as effective. So in metastatic HER2-positive breast cancer, our first line is a combination of a general chemotherapy drug plus 2 HER2 antibodies given in combination. And then we think about whether there is any brain metastases, and that can guide treatment. We now have this option of something called trastuzumab T-DXd that we talked about, which is an antibody drug conjugate, which seems to be effective regardless of whether there are brain metastases present. But we also now potentially have this tucatinib TDM1 combination as an option as well. And of course, we still have TDM1 and some older regimens of a combination of chemotherapy and HER2 antibodies that are we've been using for a long time and that appear to be very effective. So this is just showing some future combinations that might happen in the future. In triple negative metastatic breast cancer, our first line therapy is actually chemotherapy plus immunotherapy if there is that marker PD-L1 that suggests that the tumor might be responsive to immunotherapy. We do have a trial currently open at Yale looking at Dato-DXd, so one of those new antibody drug conjugates, to see if it's perhaps more effective. And especially for tumors that don't have that PD-L1 where we can't give immunotherapy, this might be a nice treatment option. For triple negative breast cancer, we also want to make sure that patients are getting DNA, what we call germline genetic testing. So in addition to looking at the mutations in the tumor itself, it's important to know whether somebody has something like a BRCA mutation, because that can make them eligible for something called a PARP inhibitor, which is an oral pill that we can give that's very effective in these particular situations. We're now going back to old pathology reports to see if potentially triple negative breast cancer is actually HER2 low. So if the staining was low, +1 or +2, where we would normally consider that officially negative, we now know that even those low amounts can respond to the TDXD, and so that can become a potential option. And then other things to look for are some other potential markers that can suggest perhaps benefit from immunotherapy. But our biggest treatment for triple negative breast cancer still remains chemotherapy. And there's a lot of trials going on right now to look at these new antibody drug conjugates to hopefully come up with better and more treatment options for triple negative breast cancer. Thank you very much, and I'm happy to answer any questions. Okay, so I'm going to go ahead and introduce Dr. Campbell. Dr. Campbell is an assistant professor of radiation oncology. She received her medical degree from Yale University, where she also completed a PhD in the Department of Immunology. She did her residency training at Yale and also completed a radiosurgery fellowship offered jointly by the Departments of Radiation Oncology and Neurosurgery. She teaches radiation oncology residents and specializes in caring for breast cancer patients.
Okay, thank you. We've had some very informative talks so far. So we'll end things with the healing rays, as I like to call them. So radiation therapy is a treatment that we use as part of breast cancer care. And radiation works by killing cancer cells, but not killing healthy cells. And the way that that happens is high energy particles fall on all cells just the same, but their normal healthy cells, when they receive the radiation, they repair their DNA. But cancer cells cannot repair their DNA because their number one priority is to keep dividing. And so they are killed when they try to divide. And that is how radiation works to kill the cancer cells, but just irritate your regular healthy cells. Radiation can be an important part of cancer care for many women, even when you've had a wonderful surgery and all your margins are negative. There can still be individual cancer cells left behind near the surgical field. And the role of radiation is to try and kill these, single remaining cells and try to reduce the risk that cancer comes back. In general, these are really some very broad brush statistics. Nowadays, there are all kinds of ways to subdivide risk categories. But in general, for early stage breast cancer patients who are treated with a lumpectomy, radiation provides about a 50% reduction in the risk of your local recurrence at 10 years and about a 5% benefit in overall survival at 15 years. Another stat that we like to quote is that for every 4 recurrences prevented, that translates to 1 life being saved in terms of overall survival. For late stage breast cancer patients who've had a mastectomy, again, we see this greater than 50% reduction in the risk of local recurrence at 10 years and about a 5% benefit in overall survival at 10 years. So I'm going to walk through how we give radiation. The first thing that we always do is set people up for a planning session, or what we call a simulation session for the radiation. We do a CAT scan, and then we design our radiation fields to make sure that we target the breast tissue that needs to be treated while protecting the rest of the body. And then we deliver the radiation therapy with a linear accelerator. So this is an example of what we might see when we've done our simulation session and we have scanned a patient. This is a CAT scan, and the darker areas are the lungs. This is the breast tissue. And here you can see the lumpectomy cavity. And so what we do is we go through and we map out exactly the three-dimensional territory in which the lungs fall, in which the heart falls, and where the surgical bed with the lumpectomy cavity is. We also map out any surgical clips that might have remained behind after the surgery. And we put a little, what we call a margin on these structures to make sure that we are really encompassing that surgical field very well. Once we've done that, we design our radiation fields. So for most cases where we don't have to treat regional lymph nodes, we can design what we call tangent fields. And those tangent fields skim across the breast tissue. And we have one field that comes from the lateral and behind the patient, and one field that comes from the medial and kind of in front of the patient. So we don't shoot the radiation directly through the body. We're skimming it across so that that breast tissue can get the benefit of the radiation, but we're blocking out everything behind it. So in the case of patients who've had a mastectomy, the technique is similar for the chest wall, and we do target the chest wall and any tissue expanders that might be placed. Or if patients have undergone autologous reconstruction before they come to us, we do target all of that reconstructed tissue. We also target the lymph node regions. So axillary lymph nodes, supraclavicular lymph nodes, meaning a small patch above the collarbone, as well as internal mammary lymph nodes that run in a chain next to the breastbone. For patients who've had a mastectomy, we will consider radiation when there is, for example, a positive margin at surgery, if there is lymph node involvement, or for tumors larger than 5 centimeters. There are also combinations of other risk factors that might cause us to consider post-mastectomy radiation. And those can be things like large centrally located tumors, triple negative cancer, or other pathologic features that make us think that the tumor might be a little bit more aggressive than average. This is an example of what the radiation fields look like on the body. Just these little lines that you see are just the traced outlines of where the beams would enter. So this is an example of a patient who has had a mastectomy and has a tissue expander placed. So we have tangent fields that swing out just a little bit to get those lymph nodes next to the breastbone. They cover the whole chest wall. And then we have this little patch right here that encompasses the upper axillary nodes and the supraclavicular nodes. It's very important for our left-sided patients that we protect the heart from radiation. There are multiple ways to do this. The most common way that we favor at Yale is something called deep inspiration breath hold technique. And what that does is we teach patients how to take a very big, deep breath to get a lot of air into their lungs. And that moves the chest wall anteriorly and away from the heart, creating a gap between the heart and where we need to treat. And this is a very effective technique in protecting the heart. It also allows us to get excellent coverage of all of the breast tissue with the radiation beam. There are other techniques to protect the heart as well, such as prone positioning, but that's the technique that we most commonly use. In terms of delivering therapy, this is a picture of our radiation linear accelerator. Patients lie on the table and the head of the machine, which we call the gantry, moves into different positions to deliver the radiation from different angles. And then it's very important for us to know that we are exactly on target, which we always are down to the millimeter. There are different ways of doing this. In Greenwich, we have a tattoo-free system that keeps track of the entire position of the chest wall in real time. We call this surface image real-time monitoring. And this allows us to not only track the exact three-dimensional coordinates of the entire curve of the chest wall, but it also allows us to calibrate our machine. So if we're doing the breath holding technique and somebody coughs or sneezes or lets the air out of their lungs, the radiation machine is going to shut off automatically and will not allow treatment to be given when the chest wall is in the incorrect position. In keeping with some of the themes of this evening, not everybody gets the same radiation. We tailor the dose and the frequency at which we give the radiation to exactly what type of tumor and what age and other risk features patients might have. These are three of the most common regimens. The first is standard fractionation. This is a little bit more of an older paradigm, but it's also still used for high-risk patients who've had a mastectomy. We give this in 25 treatments to the breast and the regional lymph nodes. And then sometimes if patients have not had reconstruction, or if they have the very high-risk cancer, such as inflammatory breast cancer, we will give a 5-treatment boost to the surgical bed. We also, for our more standard cases, for low-risk patients who've had a lumpectomy and have an intact breast, we'll often do what we call a hypofractionated regimen, which is 15 treatments to the breast and 4 treatments to the surgical bed. And that is something that we call a boost because the surgical bed is at highest risk for local recurrence. And then for our very low-risk patients who are over the age of 70 with very favorable tumor features, we have a regimen that we call the FAST regimen, and that is 5 treatments in total that are given once per week, and there's no boost with this regimen. So in general, just to kind of summarize the big kind of take-home messages about where radiation fits in different severities of cancer. So generally in early stage disease, so patients with small tumors and usually no lymph node involvement or limited lymph node involvement, the patients will have a lumpectomy, maybe chemotherapy if the oncotype indicates that, then have radiation, and then go on to hormone therapy. In advanced stage disease, chemotherapy often happens upfront, followed by surgery, and then radiation afterwards, and then potentially some additional systemic therapy. So radiation can fit at different places in the pathway, depending on the risk features of the cancer that we are trying to treat. So, since I'm the last person, so, just to kind of tie together some of the themes from tonight. So, we've heard about surgery and radiation. Those are local therapies. And then we've also heard about systemic therapies, such as chemotherapy and hormonal therapy. The local therapies are very much about the breast tissue, the lymph nodes, just that local spot, but systemic therapies work through the whole body, and both parts are very important to treat cancer effectively. And that is the end of my talk. So now I think it really is time for questions, if anyone has any.
So thank you, Allison. We've been, if the other speakers want to go up, Mike, we've been answering some of the typed in questions as things have gone on. And just certainly in summary, I want to thank the participants, the speakers, and the listeners today. And keep in mind that there are additional talks throughout the month from other areas within Connecticut. But again, to kind of bring things back home, Dr. Haykal, thank you so much for your presentation. And I know you just scratched the surface in terms of your expertise, and looking forward to collaborating with you we've already helped me with some challenging patients, and situations that require somebody with that extra oncologic thought process when it comes to doing reconstructive surgery. And it's been one of the most impressive things in my career. Other than, well, in medical oncology, I think Herceptin was a thing that was a big game changer, right? But the microsurgical techniques and developing deep flap reconstruction and other flaps, as opposed to the old tram flap, which was literally eliminating a person's core muscles, right? Has just been amazing. And I applaud your attention to detail that it takes to pull that off, right? And then I think, Mariya, my thought about the take-home message of your talk is the whole area of not just chemo, but hormonal immunotherapy is exploding. And I had the opportunity and honor of attending. Dr. Steve Rosenberg at the NCI was honored last week for his 50 years of being the chief of surgery at the National Cancer Institute, and kind of the father of immunotherapy, and just seeing that I can't say take off, but incrementally being introduced into standard of care. It is just a small part of what's so exciting in everything that's happening. And even, like you said, hormone positive breast cancers, like when it would metastasize, what'd you do? And now there's so many incredible options that, heaven forbid, like in our patient population, to be honest, and granted, they do really well because they come for screening, right? We catch these cancers early. And I'm a believer that the small cancer, they're like, well, wouldn't it matter like what you did because the survival benefit is just so good to begin with. That's the assumption that cancer stays the same over time, and it doesn't. I mean, it becomes more aggressive. It morphs over time. That's what cancer wants to do. And, so we benefit from so many survivals, right? But to know that the flip side of that is out there, for the more aggressive cancers. And Allison, as always, thank you for your thoughtful and clear presentation. I think it helped to clarify, because I think radiation is a mystery for a lot of people. Like, how do they really do it? And, I like to say that most radiation oncologists are like physicists, and you should look at your plan. You should actually look at your treatment plan with them. It's like an architectural drawing. And, it just, mentally gets you to understand, what they're actually going to be doing, so thanks again. And I appreciate all the participants as well. I think we're probably good. Let me just see if there's any more other than thank yous. I think we're good. So we all started out this morning, the Greenwich group at 7 a.m. For our breast tumor board. So I think that you're probably getting ready to sign off, right? So thanks, everybody.
Thank you so much.